Upcoming talks next week, importantly, is Dr. Rachel Lamy, and notably is the Davidson Honorary Lecture. So please join us. The following week is Dr. John Spurtis, and then a faculty meeting, and then another fellow debate. Okay. So to start off, Dr. Max Eder is currently a senior cardiology fellow here at Yale. He graduated AOA and a member of the Gold Humanism Honorary Society from Wake Forest University. He completed his residency at Yale, where he was also awarded the Samuel D. Cushlan MD Award. We were lucky enough to keep Max at Yale for fellowship, and he has won several awards for his clinical skills, including Consultant of the Month, and more recently, receiving the Fellow of the Year Award by the Internal Medicine Residency Program. He will next be pursuing a career in non-invasive cardiology and will be starting as an assistant professor of cardiology at UConn Health this summer. Next, Dr. Greg Rubenfeld is currently a senior cardiology fellow at Yale here as well. He graduated AOA from NYU School of Medicine and was awarded the Eve R. Fletcher Memorial Award for Excellence in Internal Medicine. He then stayed at NYU for internal medicine residency, where he was given the Intern of the Year Award and later served as chief resident. We are grateful that he joined us at Yale for fellowship, where he has been a pivotal part of the educational program here, serving as one of our chief fellows. He will be pursuing a career in non-invasive cardiology and will be starting as an assistant professor of cardiology at Northwell Health this summer. And it's been my pleasure to work with both of them over the time of my tenure as well. So now I'd like to call up Dr. Eder to the stage.
Thank you, Dr. Clark, for that really warm introduction. So, as Dr. Clark said, I'm Max Eder, one of the clinical fellows here in the section of cardiovascular medicine. And today I'll be presenting on atherogenic lipoproteins and atherosclerosis in the young adult. When I finish, Dr. Rubenfeld will take the stage to talk about left ventricular non-compaction cardiomyopathy. I have no financial or non-financial conflicts of interest. And in terms of learning objectives for this talk, I'd love for us to review current guidelines as they pertain to treating elevated LDL-C, review emerging arguments for treating atherogenic lipoproteins at a younger age than may be currently recommended by the guidelines, and then review potential future directions for research in this exciting area. I think it's best to start with a clinical question to get our minds thinking about this question. So a handsome and charismatic third-year cardiology fellow with minimal past medical history shows up in your cardiology clinic. He is concerned as recent blood work revealed an LDL-C of 146, and he's asking you if you think he should start a statin. He's 34, has a normal BMI, exercises 3 to 5 days per week, a mix of cardio with running and swimming and yoga. He eats a relatively healthy diet, though on occasion will indulge in Taco Bell. He has never smoked tobacco and drinks socially with his co-fellows. His parents are both living, neither have any notable past medical history, and notably there's no significant family history of cardiovascular disease. You can see his total cholesterol, HDL-C, triglycerides, and LDL-C reflected in the panel in the lower right hand of the screen. I'll just give us a moment to think about how you would treat this patient and what you would advise them. So I think there's a lot of reasons why a reasonable clinician might decide not to treat this patient with a statin. For one, currently there's no strong guideline recommendation to start statins in this patient. There's a complete lack of randomized controlled trial data in this patient population. 10-year event rates are incredibly low in this patient population. If you use the most recent AHA Prevent model, this patient's 10-year risk of a cardiovascular event is 0.6%. And so the number needed to treat to prevent one event in the next 10 years in this patient population is inevitably going to be high. There's unclear cost effectiveness of treating such a low risk population for the duration of time that you would need to reduce lifetime events. And although there's some data on the long-term safety and efficacy in a familial hyperlipidemia patient population, this is less well established in the general population amongst patients this age. And maybe there's perceived room for lifestyle modifications. The fellow can work out more. He can stop eating Taco Bell, although he probably won't. And clinical inertia and concerns over adherence also come into play. I've had cardiologists tell me that they can't even get their high-risk secondary prevention population on a statin, and that's where they want to focus the bulk of their energy rather than getting otherwise healthy young 30-year-olds on statins. And in the guidelines, you'll notice that for patients aged 20 to 39 years, the guidelines would recommend estimating lifetime risk, encouraging lifestyle modifications, but they would only really recommend considering a statin if the patient had a family history of premature atherosclerotic disease or an LDL-C greater than 160, neither of which the patient in the question stem has. And you'll notice looking at this overview of the lipid guidelines that unless the patient has familial hyperlipidemia with an LDL greater than 190, age over 40 with diabetes, or intermediate to high risk, it's relatively hard for any patient to get a class 1 recommendation to be on a statin at a young age. And we know there's a strong age bias in the pooled cohort equations where a patient with an LDL who's 40 years of age with an LDL of 180 will be low risk if they have no other cardiovascular risk factors. And a 75-year-old patient with an LDL of 70 and otherwise optimally controlled risk factors will be classified as intermediate to high risk and have a class 1 indication for a statin, purely because of their age. Which brings me to my first key point, that the guidelines as they're currently written focus on treating older individuals with elevated risk profiles, which are in essence the types of patients who historically have had cardiac events. And the guidelines as they're currently written do not focus on limiting lifetime exposure to atherogenic lipoproteins. I'll now spend the rest of the talk looking towards emerging arguments for more aggressive lipid lowering in young patients, which I hope will be reflected in the future guidelines. So I think it's worth recognizing that the atherosclerotic disease process starts incredibly early. This was a paper published in 1998 looking at 204 young persons who had died in Bogalusa, Louisiana, aged 2 to 39 years of age. They principally died from trauma, accidental death. These were not cardiovascular events. But since every patient had an autopsy, they were able to clarify the amount of fibrous plaque and the prevalence of fibrous plaque in the aortas and coronary arteries of these patients. Interestingly, because the Bogalusa heart study had also been carried out in the same area of Louisiana, they had antemortem risk factor data on 93 patients. So you'll see here that shockingly, even patients as young as 2 to 15 years of age can have fibrous plaque in their coronary arteries. And when you get to the age range of the patient in the question stem I presented at the beginning of the talk, 69% of patients will already have fibrous plaque in their coronary arteries. And obviously the prevalence you can see in this graph clearly increases with age. When they looked at what antemortem risk factors were most strongly correlated with the presence of fibrous plaque in the coronaries, it shouldn't be surprising to us. Things like BMI, systolic blood pressure, and LDL-C cholesterol were some of the highest and strongest correlations with the presence of plaques in the aorta and coronary arteries. And when we talk about LDL-C being a risk factor for subclinical atherosclerosis, I'm not talking about massive elevations in LDL-C. This was a study of 1,800 patients from the PESA study, the Progression of Early Subclinical Atherosclerosis study, and they looked at 1,800 patients without other conventional cardiovascular risk factors. So all these patients had a normal blood pressure, no diabetes, a total cholesterol less than 240, and they had to have an LDL-C less than 160. They used 3-dimension vascular ultrasound to look at atherosclerosis in the carotids, the femoral arteries, then the aorta, and they also used coronary artery calcium scoring to look for the presence of CAC in the coronary arteries. What you can see here on the graph is that the prevalence of atherosclerotic disease, subclinical atherosclerotic disease, increases with increasing concentrations of LDL, but it starts at relatively low levels of LDL. Even patients with LDL as low as 60 to 70 will have some subclinical atherosclerosis. And when we get to these boxes, with the red box representing no atherosclerosis, the gray box representing focal disease, the orange box representing intermediate disease at 2 to 3 sites, and the blue box representing generalized disease, when we get to the LDL 140, 150, like the patient who presented in the question stem, you can see that 26% of patients will have atherosclerosis at multiple vascular sites, and 8% will have generalized diffuse atherosclerotic disease. When they looked at all the risk factors that would predict subclinical atherosclerosis in these patients, they found that LDL-C was the strongest modifiable risk factor. Which brings me to my next key point, that subclinical atherosclerosis starts at a young age, is highly correlated with LDL-C, and occurs even in individuals without other conventional risk factors. Now, I think it's important to note that subclinical atherosclerosis, while it's something that's happening to a lot of us from a young age, is also a potent predictor of future cardiovascular events, and the risk factors that mediate subclinical atherosclerosis are also a potent predictor of future cardiovascular events. So this was a study that was published about 2 years ago in the New England Journal of Medicine. They looked at almost 40,000 patients aged 3 to 19 years of age who had data collected in their childhood on BMI, systolic blood pressure, smoking, cholesterol levels, and triglyceride levels. They then used death record data, medical chart data to follow up these patients a mean of 35 years later in life to look at the correlation between these childhood risk factors and the risk of a fatal cardiovascular event. And so what they did is they took all of these childhood risk factors and they combined them into a combined Z-score, which reflected total cholesterol, triglyceride level, youth smoking, BMI, and systolic blood pressure. Now in the graph here, you can see that for every 0.5 standard deviation increase in Z-score, there's a significant increase in the risk of fatal cardiovascular events, and that the curves continue to separate over time, indicating, at least to me, that childhood risk factors are a powerful predictor of future cardiovascular events, and maybe we should be looking to target these risk factors earlier in life than would be recommended by the current guidelines. When it comes specifically to atherogenic lipoproteins, there's this interesting study published in 2016, which was an examination of the InterHeart study. They looked at 12,000 patients with a first acute MI and 14,000 age and sex matched controls without known cardiovascular disease. The study was carried across 262 centers in 52 countries, and all the participants of the study had blood samples including apolipoprotein B, HDL-C, and LDL-C. And they used logistic regression to compute the odds ratio for myocardial infarction per 1 standard deviation change in each lipid marker while controlling for other cardiovascular risk factors. What you can see here is that the odds ratio for myocardial infarction at a younger age increases substantially per standard deviation change in any of these lipid markers, but this relationship is attenuated over time, whereby changes in LDL-C and other lipid markers are most predictive at a younger age and less predictive over time. And the relationship that I think explains this is what's called the cumulative exposure hypothesis, or rather LDL-C years, that the persistence of a risk factor and how long and the magnitude of a risk factor, as well as its persistence over time, is really what mediates cardiovascular events. And so in a patient in their 70s who's already developed a significant atherosclerotic plaque burden, relative changes in LDL-C may not completely eliminate the risk of that plaque that's already built up. But in younger patients who have not developed a significant plaque burden, changes in LDL-C can really alter the time course of their disease. And so when we get to the concept of LDL-C years, there's this amazing investigation in 2020 in JACC, where they looked at the effect of cumulative exposure of LDL over time. And so for this study, they used the CARDIA data set, the coronary artery risk development on young adults study. and they looked at 5,000 patients who were enrolled from 1985 to 1986 and then followed for 30 years with an overall retention rate of 71% by year 30. For this LDL-C study, what they did is they broke that 30-year period of time into an observation window, anytime from enrollment until the patients reached 40 years of age, and then a prediction window where they looked at cardiovascular events that were predicted by the observation window. For the observation window, they calculated an area under the curve of LDL exposure, basically the magnitude of LDL elevation that the patient was exposed to and the number of years that the patient had that exposure, which captures both the persistence of this risk factor over time as well as the magnitude of this risk factor. And you can see here clearly that for each quartile increase in area under the curve in LDL-C exposure, there's a significant increase in the risk of a cardiovascular event. They also found a very interesting interaction between the time course of area under the curve exposure. So these top two groups here, the one in blue and the one in red, you'll see both had an area under the curve greater than median for the trial, but they had different time courses. The blue group with the slope less than 0 had a initially high area under the curve, and then later in life had decreasing LDL concentrations. The second group achieved their area under the curve later in life. They had lower LDL to begin with, but had increasing LDL levels over their lifespan and developed their subclinical atherosclerosis and LDL exposure much later in life. And so patients with early area under the curve, which likely correlates to early subclinical atherosclerosis, had much higher event rates than those who achieved the same magnitude of LDL exposure at a later time point. And so I think this concept provides powerful ways for us to impact our patients, because this means that if we are truly able to modify the time course of LDL exposure, we can delay or even prevent the onset of clinical atherosclerotic events. And so here you'll see different slopes of kind of cumulative LDL exposure, with this blue box here representing the threshold for the onset of clinical cardiovascular disease, when subclinical disease becomes clinical. And that might be because a plaque burden gets to the point where it's unstable and a plaque ruptures, or it begins impinging on the lumen of a vessel. But patients with severe hypercholesterolemia will reach that clinical time point for disease much sooner than patients who have lifelong low LDL and have good control of their other risk factors. So I think if we think about minimizing our patients' area under the curve and minimizing their lifetime exposure to LDL, we can potentially alter our patients' trajectory from being the red box, the orange box, or the yellow box to hopefully being the green box, where they won't have a cardiovascular event in their lifetime. And if this sounds like a radical idea, I think this is a concept that's already been proven in our familial hyperlipidemia patient population, whereby patients who are homozygous for FH develop clinical atherosclerotic disease much earlier than patients who are heterozygous, who in turn develop it much earlier than patients who have no familial hyperlipidemia. And of course, it's been well demonstrated that patients with loss of function mutations in PCSK9 will have a very low risk of any cardiovascular event in their lifetime. Which brings me to my next key points, that risk factors early in life are a strong predictor of clinical events later in life. And by minimizing lifetime exposure to atherogenic lipoproteins, we may be able to alter the time course of atherosclerotic events. For the remaining time I have for my talk, I'd like to look towards the future of this area. So this was a recent article in November in JACC looking at determinants of progression and regression of subclinical atherosclerosis in adults. This was another analysis of the PESA cohort, the progression of early subclinical atherosclerosis, where they looked at 3,500 patients aged 40 to 55 years of age. They initially did 3D vascular ultrasound on these patients at enrollment, and then at time point 6 years later. And they saw that clear different phenotypes of patient populations arose. There were patients who had stable disease or stably had no disease over the 6 years. Then there were patients who inevitably progressed, which was about 33% of the patient population. But there's this fascinating cohort of patients, this fascinating phenotype of patients who had plaque regression over the 6 years of the study. And this is just a demonstration of how they tracked progression versus regression. So on the upper boxes, you'll see examples of carotid ultrasound. In the lower boxes, you'll see examples of femoral ultrasound. Left shows patients with progression where they had baseline disease or maybe baseline minimal disease, but then 6 years later, they had a significant increase in their plaque burden by 3D ultrasound. On the right, you'll see the regressors who had clinical disease at baseline, but then at 6 years of follow-up had almost no evidence of that plaque that was initially seen. And when they looked at what risk factors determine progressors versus regressors, again, it's something that we all know, right? Patients who had higher LDL-C, higher systolic blood pressure, smoking, male sex tended to have progression of their atherosclerotic burden. And patients who had lower LDL-C, were non-smokers, younger age, and women tended to have regression. And of all the things they looked at, LDL-C was again the strongest predictor of progression versus regression. Now, you might be curious, because I presented a lot of non-randomized controlled trial data, what kind of randomized controlled trial evidence I'd have for treating this patient population. And unfortunately, I have none. The trials have not really been done. But in a recent issue of JACC, they talked about this future trial that they hope to enroll in, the PreCAT trial, which would look at treating patients 20 to 39 years of age with an LDL-C greater than 70 aggressively to bring their LDL-C less than 70, to bring their systolic blood pressure less than 120, to treat any other comorbid conditions like diabetes, and then to do vascular ultrasound at set intervals and see how their subclinical atherosclerotic burden progresses. They would use a primary endpoint of change in atherosclerotic plaque burden, and then the secondary endpoint would be hard events. And the reason I think they're using subclinical atherosclerosis is because event rates in this patient population are so low that you would need to follow this patient population for decades or have an enormously large trial in order to just track hard events, but they can use subclinical atherosclerosis as a surrogate endpoint. And so patients would be randomized 1-to-1 to standard of care, which is, essentially the guideline recommendations that I shared earlier, versus active treatment with diet and lifestyle recommendations, inclisiran plus minus statin and ezetimibe to keep LDL-C less than 70, 1 to 2 drug antihypertensive therapy to keep systolic blood pressure less than 120, and then aggressive treatment of any hemoglobin A1C greater than 6.5 with follow-up every 6 months. And at baseline 2.5 years, 5 years, they'd look at the burden of subclinical atherosclerosis in the carotids, in the coronary arteries, in the femoral arteries, in the aorta, using similar methods as was used in the PESO study. And so in order to summarize the talk, I'd like to say that atherosclerotic disease starts at a young age, even in patients who have been historically categorized as being low risk. Risk factors early in life are a potent predictor of cardiovascular events later in life. Age, although we know cardiovascular events increase with age, it may be that age serves more as a marker of cumulative years of exposure to atherogenic molecules and other risk factors, rather than a mediator of the events itself. And treatment of risk factors early in life may have the greatest magnitude of benefit. Guidelines and the pooled cohort equation may lead us currently to overly focus on treating LDL-C later in life rather than minimizing the cumulative exposure to LDL-C over a person's lifetime. And randomized controlled trial data would be greatly appreciated in this patient population. And so to follow up that clinical question from the beginning, that anonymous third-year cardiology fellow did start himself on 10 milligrams of rosuvastatin And his most recent lipid panel showed a greater than 50% reduction in LDL-C, dropping from 146 to 71. For acknowledgements, I'd love to thank Dr. Spatz and Dr. Jaimo for their amazing overview of my slides, for talking me through this subject, for their critical appraisal of this talk, and Greg Rubenfeld, who I'm honored to be sharing the stage with again today, who also practiced multiple times through this presentation with me and looked through all my slides multiple times. I'd like to welcome him to the stage for his talk on non-compaction.
Really, it is an absolute privilege to be sharing the podium once again with Dr. Reeder. And I must admit, I am at least to some extent grateful that today I will not be locking horns with him in a debate, but instead we will be talking about something entirely different. Today, we will be unpacking non-compaction. I have no financial or non-financial conflicts of interest to disclose. And the learning objectives for this talk will begin with reviewing the definition, the pathophysiology, and the epidemiology of non-compaction. We'll discuss the different imaging criteria used to diagnose non-compaction. And hopefully by the end of this talk, we'll have gained insight into the different clinical manifestations, the management considerations, and prognostication in non-compaction. Now, with regards to terminology and definitions, this is already a controversial area, and it's not entirely clear what we're supposed to be calling the entity of non-compaction. For simplicity's sake, I will be referring to this condition as non-compaction, and we'll discuss some of the different opinions along the way. But non-compaction is really typified by a bilayered myocardium with a layer of excessive trabeculations and a more compacted epicardial layer. And the extent, the location within the heart where these excessive trabeculations can manifest is really variable from patient to patient. Non-compaction was originally classified by the American Heart Association as a genetic cardiomyopathy. And earlier, the European Society of Cardiology had thought of non-compaction to be an unclassified cardiomyopathy, but has later changed their tune to thinking of non-compaction as more of a phenotype, perhaps. And the term non-compaction in general being a misnomer that should be abandoned. And as we'll see, truly everything about non-compaction, from its name to its pathobiology to how we diagnose and treat patients with this, is the subject to ongoing controversy and debate. We had originally thought that non-compaction had began with an arrest in appropriate embryologic development, where there was an excessive trabecular meshwork in the endocardium that through time would compact to form the final compacted myocardium. And a halting of myocardial morphogenesis would lead to the continued presence of excessive trabeculation. But more recently, this idea has been called into question and has had doubt cast upon it due to the lack of true scientific data that this is indeed what's occurring. Instead, there's been a frame shift to thinking about embryologic development occurring along the lines of what's called allometric growth, or that there's different rates of growth of different parts of the heart. And there is a trabecular layer and a compacted layer. And the compacted layer is not formed through compression of the trabecular layer, but rather over time in normal development, the compacted layer just grows more than the trabecular layer. And in patients that have excessive trabeculation or non-compaction, it's just because the trabecular layer is growing more than it should, proportionally speaking. And with regards to the heterogeneity of non-compaction, it begins with its genetic underpinnings and it progresses to its clinical manifestations. It can be congenital or acquired, familial or sporadic. It can be seen in isolation or in association with other structural diseases, both cardiovascular and non-cardiovascular, with a literature base describing it in association with neuromuscular disorders, and a number of studies noting that non-compaction can exist in the company of congenital heart diseases and other cardiomyopathies. And the clinical manifestations can range anywhere from patients who are asymptomatic to the most profound iterations of cardiovascular dysfunction, with sudden cardiac death being described in a high percentage of patients, and patients developing end-stage heart failure, malignant arrhythmias, stroke, and thromboembolism along the way. And this vast spectrum of different clinical manifestations has led to notions that perhaps we can better categorize non-compaction by subtyping it by the company it keeps in the different clinical manifestations that patients can manifest. And there's been as many as 9 different subtypes described in pediatric populations and 7 in adult populations. And these different subtypes have never really gained much traction. Instead, I think it's just informed our understanding that truly non-compaction can present in a myriad of different ways. With regards to the genetics of non-compaction, a genetic inheritance has been described in about 30 to 50% of patients with non-compaction, most typically with autosomal dominant modes of inheritance, but it has been shown to have associations with X-linked patterns of inheritance, autosomal recessive patterns of inheritance, mitochondrial patterns of inheritance as well. And the penetrance is quite variable. Genes encoding sarcomeric, desmosomal, cytoskeletal proteins, among other types of proteins, have been all described to be seen in patients with non-compaction. And the different gene mutations do appear to confer different risks for cardiovascular events. And part of the confusion we have with what non-compaction is because it is overlapping with other cardiomyopathies. And a number of the genes that have been implicated in non-compaction can be seen in other cardiomyopathies as well, lending credence to the notion that non-compaction may not be its own cardiomyopathy, but perhaps a phenotypic expression seen in other cardiovascular diseases. And this is just a 30,000-foot view of the many different genes that have been described in relation to non-compaction. Turning to the epidemiology, prevalence rates have been described to be as frequent as 0.01 to 0.3% of adults referred to TTE, but much more common among patients with heart failure undergoing echocardiograms. And it's more often seen in men than in women. And the age of diagnosis can be highly variable, though the median age of diagnosis among adults is between 40 to 50 years of age, and in pediatric populations between 5 and 7 years of age. And as we think about approaching a diagnosis, we are mired down with a number of challenges. Firstly, there is a strong literature base to believe that many patients may have prominent trabeculations of a benign etiology. And we know that in about a quarter of pregnant women, there can be the presence of excessive trabeculations, and we can see this as well in competitive athletes. And if that didn't make the diagnosis difficult enough, we have our own limitations of our imaging modality to contend with, and the presence of thrombus, aberrant cords, fibromas can all serve as mimickers of non-compaction and further obfuscate the diagnosis. And in the next few minutes, we'll review the diagnostic criteria, which are really either echocardiographic criteria or cardiac MRI criteria. But it's worth noting from the outset that in conjunction to our imaging modality, a thorough history, a family history, the ECG, and looking at cardiac MRI, not just for the presence of excessive trabeculation, but for late gadolinium enhancement, will not just help in establish or reject a diagnosis, but will also be very helpful in risk stratification. About a decade ago, a paper in JACC Cardiovascular Imaging recognized the challenge of teasing out what might be a benign iteration of excessive trabeculation versus a more pathological non-compaction subtype. And they noted that very simply, sometimes just looking at an ECG may point you in the right direction, whereas in athletes that have this epiphenomena, increased trabeculation due to changes in loading conditions, they may more classically have an ECG that may show an LVH pattern, but not really pathologic ST wave changes, whereas in somebody with non-compaction, you may see deep symmetric T wave inversions. And putting that together with a more robust assessment, we can get a sense that in making the determination of a normal variant versus non-compaction, we will need to rely on all of the tools at our disposal. We'll need to assess for symptoms, family history, look for other patterns of conduction disease on the ECG, assess diastology, and ascertain whether or not the patient has had the presence or absence of atrial or ventricular arrhythmias, and even incorporate multimodality imaging into the diagnosis. And with regards to the diagnosis, we turn to the 2019 HRS guidelines for arrhythmogenic cardiomyopathies, which they had described non-compaction as being one of them. And we now struggle with the uncertainty of 2B recommendation land. And so in a patient suspected of non-compaction, there's the suggestion to employ either echocardiographic or cardiac MRI criteria to achieve a diagnosis. There are 3 echocardiographic criteria that have been described, and the most frequently used is the Jenny criteria, which suggests that at a baseline, these patients should have the absence of concurrent cardiac structural defects. And in addition, we'll need the presence of a bilayered myocardium with the ratio of a non-compacted to compacted myocardium to be greater than 2 at end systole in the short axis view, and have the presence of intratrabecular recesses that fill with blood from the LV cavity evidenced by color Doppler. In addition to other criteria, the Chin criteria and the Stolberger criteria are in use. The Chin criteria, very similar to the Jenny criteria, looking at a ratio of non-compacted to compacted myocardium, though the measurements are made in diastole rather than systole, and how the exact measurements are made are slightly different. And the Stolberger criteria, which looks, rather than at the ratio of non-compacted to compacted myocardium, looks more at the number of trabeculations, with 3 or more large trabeculations in the apical 4-chamber view being consistent with a diagnosis of non-compaction. Unfortunately, across these 3 different diagnostic criteria, the agreeability is quite poor. And in a study looking at about 200 patients with non-compaction, only about 30% met the criteria for all 3, whereas the remaining 70% was positive in one of the criteria or 2 of the criteria and negative in the other. And in turning to cardiac MRI, we know that MRI does offer us the benefit of higher spatial resolution and may allow for better delineation between non-compacted and compacted myocardium, and will allow us to better visualize the apex fault tendons and aberrant bands and hopefully see through some of these masqueraders. There are 2 cardiac MRI criteria that are frequently in use. The first is the Peterson criteria, which looks for a ratio of non-compacted to compacted layers of greater than 2.3, and the Jacquard criteria, which looks at a trabeculated LV mass being greater than 20% of the total LV mass. And we can see just from this picture that cardiac MRI really allows us to get a clear sense of the borders and demarcation of the non-compacted and compacted layers. Back to the 2019 HRS guidelines. So again, a 2B recommendation to use one of these 5 different criteria, the 3 echo criteria and the 2 cardiac MRI criteria that we've reviewed. And in addition, there's a 2B recommendation to consider using cardiac MRI in particular among patients with non-compaction who have the presence of ventricular arrhythmias. And this is not merely to achieve a diagnosis, but aside from just looking at the presence of trabeculation and the ratio of trabecular myocardium, to look for late gadolinium enhancement, which has been shown to be a marker of worse prognosis and can hint towards a patient population that is at higher risk for ventricular arrhythmias and adverse cardiovascular outcomes. And tackling the clinical manifestations of non-compaction in practice is another area of difficulty. Really, the protein manifestations of non-compaction range from asymptomatic presentations to life-threatening diseases, but the 3 cardiovascular manifestations that we'll spend a little bit of time with include heart failure, arrhythmias, and thromboembolism. And we'll take each in turn. In about 2/3 of patients with non-compaction, these patients will develop some element of systolic dysfunction over time. And this is thought to be related to subendocardial hypoperfusion in the non-compacted areas. And there has been at least some evidence on PET, SPECT, and cardiac MRI that there is poor blood flow to these areas, perhaps related to failure of microcirculation development in these parts of the heart. And in addition, diastolic dysfunction of the hypertrabeculated ventricle has been implicated as well. With regards to arrhythmia and electrical disturbances, about 1/4 to 50% of adults with non-compaction will have some type of bundle branch block on their ECG. About 1/4 will go on to develop some type of supraventricular arrhythmia, with about 5 to 30% or so developing AFib. And ventricular arrhythmias are seen in about 18 to 47% of adult patients with non-compaction, and sudden cardiac death seen in almost 20% of patients with non-compaction. Turning to thromboembolism, I think the mechanism behind this is one of the more facile to wrap our head around, with the deep intratrabecular recesses leading to sluggish blood flow and the violation of the 3 legs of Virchow's triad. And the rates of thromboembolism in patients with non-compaction is quite variable, but has been estimated to be in the order of 4 to 29% of patients over their lifetime. And there's some evidence that suggests that the percent increase in non-compacted myocardium can be strongly associated with the level of risk of developing a thromboembolic event. So now we'll discuss some of the different facets of managing non-compaction back to the 2019 HRS guidelines. And here we'll touch upon a moment of controversy in the literature. The 2019 HRS guidelines has suggested that in patients with a diagnosis of non-compaction, there is a 2A recommendation to consider genetic counseling or genetic testing in these patients. Around the same time, the Heart Failure Society of America took a different approach, suggesting that non-compaction was less a cardiomyopathy and more a phenotype. And in patients that happen to have non-compaction phenotype, serendipitously diagnosed in the absence of symptoms or other cardiovascular abnormalities, that we shouldn't be pathologizing these patients, we shouldn't be subjecting them to genetic testing. What about management of arrhythmias and risk of sudden cardiac death? And so the 2019 HRS guidelines do comment on this as well, offering a class 1 recommendation for ICD implantation in patients with non-compaction who have had VT and syncope or resuscitated cardiac death, or a 2A consideration in patients that have non-compaction with a reduced EF and non-sustained VT. And this may already flag up for most of us, raising an eyebrow, that there's really nothing unique about these recommendations to non-compaction. And we would have a class 1 recommendation to be putting in ICD for resuscitated cardiac death or VT associated with syncope in any patient, regardless of the presence of non-compaction. And the 2022 ESC guidelines for the management of ventricular arrhythmias pick up on this, and they suggest that when you think about approaching ICD implantation in patients with non-compaction, just treat them as you would any other patient with cardiomyopathy. A 2A recommendation to employ other recommendations elsewhere for patients with a general type of cardiomyopathy. And then with regards to the thromboembolism and attenuating that risk, the 2019 HRS guidelines suggest that in patients with non-compaction who have AFib or a prior thromboembolic event, the class 1 recommendation to start anticoagulation. And this, I think, would be sort of similar to the way we would approach AFib in somebody with HCM or amyloidosis. Ignore the CHADS-VASc score. The mere dint of the fact that they have AFib in combination with non-compaction would be impetus enough to consider anticoagulation. But perhaps a more vexing issue is approaching risk reduction in patients with non-compaction who just have a reduced ejection fraction. And this is an area of uncertainty. There's a 2B recommendation to consider anticoagulation in these patients. And I think this would be an area which future research will hopefully clarify for us, but in the interim, shared decision-making with our patients is probably the best strategy forward. Now, very recently, the ESC had put out their guidelines in the management of cardiomyopathies. And in this guideline, they had suggested that we move away from the term non-compaction. We cease to think about non-compaction as a cardiomyopathy unto itself, but more of a phenotypic expression. And for reasons that we mentioned earlier, that non-compaction may be a misnomer and we should be replacing it with the term hypertrabeculation. And in the very same year, along the same lines, Dr. Peterson, the author of one of the cardiac MRI criteria, put out an expert panel paper where he suggests we move away from the term non-compaction towards excessive trabeculation. We think about managing patients with this phenotypic expression, not by the pattern of their trabeculations, but by the clinical manifestations that they have. And recognizing that in pregnant patients and in athletes, we may see excessive trabeculation that can be a normal variant related to dynamic changes in loading conditions. And while I do think that this was helpful, I felt that if I had a patient show up to my office with excessive trabeculation, question of symptoms, I would be no better to figure out how to risk stratify these patients and manage them in real time. And hopefully, to provide us some guidance with this, we'll turn to two papers in the remaining time we have. The first came out in Mayo Clinic and was published in the Journal of American Heart Association in 2021, a retrospective study looking at 339 patients with non-compaction, and they followed these patients up for 6 years. And what they found was that in patients who had non-compaction but a normal EF and only isolated apical non-compaction, that their survival was similar to age and sex matched cohorts. But in patients that had either a reduced ejection fraction or the extent of their non-compaction proceeded to the mid or base of the heart, these are patients that had survival that was lower than expected and suggests a patient population at higher risk for adverse outcomes. Similarly, that same year in JACC, a retrospective study looking at almost 600 patients and followed them up for 5 years found that in this cohort of patients with non-compaction, over 5 years, the risk of MACE was quite high, 38%, with nearly 20% developing heart failure, 15% having ventricular arrhythmias, 3% systemic embolism, and 6% having all-cause mortality. But something that was particularly powerful, and I think something that may inform what we do today, is that in this high-risk cohort, among the patients that had a normal EKG, a normal EF, no late gadolinium enhancement on their MRI, and no familial history, they had 0 adverse cardiovascular events over the entire duration of follow-up, lending credence to the notion that in patients that just have excessive trabeculation and the initial cardiac workup is thoroughly negative, that reassurance is perhaps the best approach. But in patients that have an abnormal ECG, that have a depressed ejection fraction, that have late gadolinium or a concerning family history, that these are patients that may be at higher risk for cardiovascular outcomes down the road, and closer longitudinal follow-up would probably be the most prudent course of action. And so where does this leave us in 2024? In need for international registry data to better understand the phenotypic range of non-compaction or excessive trabeculation, to figure out how to best risk stratify patients for the development of heart failure, arrhythmia, or embolism. And hopefully with this, one day, to have clarity on how to diagnose and treat these patients. And with that, I'd like to thank Dr. Clark for her mentorship and guidance with this talk. I'd like to thank Dr. Eder for reviewing my slides and for his insightful feedback. I appreciate your attention. I'd like to welcome Dr. Eder back to the stage, and we'd be happy to take any questions.
Gentlemen, fantastic job from both of you. I guess my first question is for Dr. Eder. You didn't touch on genetic testing for FH, so I was wondering, are any of your recommendations tempered by or influenced by the presence or absence of genetic testing? How would you approach it?
Yeah, I mean, I think for anyone who has a substantially elevated LDL-C or sorry. I think for anyone who has a substantially elevated LDL-C, non-HDL-C cholesterol, or apolipoprotein B, that would indicate that they have significant hyperlipidemia. I would advocate for genetic testing because I think in that case, your treatment decision not only extends to the patient in front of you, but also their family members, right? Making a diagnosis and making sure their family members who are screened and who could have this condition is really important. And there's an interesting study in 2019 in the New England Journal of Medicine where they looked at patients who had been on statins since childhood and their rates of cardiovascular events compared with their parents who were born before the dawn of statins. And the children who were on statins had much lower rate of cardiovascular events than their parents. And so it's clear that, by treating an FH population appropriately, we can really minimize their risk. And so I think there is benefit to making a firm diagnosis, getting them on appropriate treatment, and treating their relatives.
Right. And if I could ask Dr. Rubenfeld, a similar question along a similar vein. It doesn't appear to be a monoallelic disease, but does you touched on it a little bit, but does genetic testing affect your risk calculation, not just for the diagnosis, but does it affect your risk calculation? Should it be performed in all these patients?
So I think it's a great question. And we definitely do know that depending on which type of gene is involved, the risk of adverse cardiovascular events, it can vary. And so there are some genes that are associated with more of a benign course of illness and some genes associated with higher event rates. But in terms of genetic testing everybody, I think that the initial approach would be to first perform a robust imaging assessment, including cardiac MRI, ECG, maybe even Holter monitoring to assess for subclinical arrhythmias. And if that entire workup is negative in a patient with normal LVEF, rather than looking for a genetic mutation, I think reassurance would be the best course of action. But in somebody who does have bona fide disease or even minor abnormalities on their ECG, that may be another avenue to help understand, does this patient have a pathologic iteration of excessive trabeculation or non-compaction, or more of a benign course if the genetic workup is thoroughly normal?
There's a question from Brian at Canby for Matt. Could you comment on the role of cardiac CT in your patient in relationship to the younger population?
Yeah, absolutely. I'd love to. So I think I have a extra slide in here somewhere on that. Yeah, you all see that. So I expected to get a question on this. So, I think as with most populations, CAC greater than 0 in a young patient is a powerful risk predictor, right? That indicates someone who's developed early subclinical atherosclerosis, and I think you should treat them aggressively. And that data has been shown both in the CAC consortium data set with younger patients, as well as with the Cardia data set, that patients who have any detectable CAC have a higher event rate than young patients with a CAC of 0. I think the issue is in young patients, we know that soft plaque can precede the development of calcified plaque by decades. And you can see here on the graph that when someone converts from having soft plaque to having calcified plaque is very unpredictable. Early converters represented by the blue line might convert sometime in their 30s, but average converters might not, start demonstrating calcified plaque until later in life. So I think if you get a calcium score on a young patient and it's positive, that's a very powerful marker of high risk. But if you get a negative CAC score on a young patient, I don't know that confers the same levels of protection as someone later in life, because they could have a substantial amount of soft plaque that you're missing by that test.
One more question. This is from Brad. Brad, you can unmute yourself and ask the question.
Yeah, I was just wondering, because this exact scenario that I posed came up in my clinic recently. I had a new patient who came who had an LDL-C on outside testing of 190. Well, it's 189, but like effectively 190, in the range where I was very concerned for heterozygous familial hyperlipidemia. And then he was very medication averse, and so we settled on repeating his lipid panel. He said he had made several lifestyle modifications, including exercising more and cutting out red meat and carbs, not entirely. But his repeat test came back and his LDL-C is now 120. So now I'm kind of at a crossroads where he doesn't have a family history of premature coronary disease, but he obviously did have the one LDL-C of 190, definitely in the range of concern for familial hyperlipidemia. So would you send this guy for genetic testing? Would you treat him at least to an LDL goal of less than 100, or since he doesn't have a family history of premature coronary disease, or what would your overall approach be?
Yeah, thanks, Brad. That's an excellent question. So I think that's tricky, right? Because you only have 2 data points, and one of those data points is suggestive of a potential familial disorder. I mean, I don't know what their lifestyle was like before enacting those lifestyle changes, but if they had an LDL of 190, then I would potentially consider genetic testing and talk to them closely about their family history. In terms of treatment goals, like how low is low enough, I think it's really hard to know with the present data. I mean, I presented that slide earlier that shows that even what's been traditionally considered normal levels of LDL, LDL around 100, people still develop and have progression of subclinical atherosclerosis. And so I think as low as you can get it, as early as you can get it, probably will have the biggest magnitude of benefit. But of course, not every patient is willing or wants to take a high intensity statin, and there's a lot of side effects that could potentially occur at higher doses. But I probably would treat that patient, right? We know that their LDL historically with lifestyle modifications is at least 120. When they're less adherent to their lifestyle modifications, it's as close to 190. And so that's someone that I think probably, realistically should be on a statin if that's the magnitude of LDL elevation. The other thing is we know that LDL-C doesn't completely encompass their entire residual risk, even when treated on a statin. And so I'd be curious to see what their non-HDL-C total cholesterol is, as well as looking at apolipoprotein B. That might give a more overall estimate of their overall estimate.
And LPA.
Yeah,
Can I-
LPA, which should
Yeah.
be partially encompassed by the non-HDL-C cholesterol.
LPA and ApoB are pending. Those take a little bit of time, but yeah, that I had similar thoughts. Thanks.
I have a question that maybe Ari can go next. So the question really, first of all, wonderful job, both of you, for kind of going deeper into a topic. And it clearly seems you learned a lot through the process, so congratulations. The question to Greg is about when or do you ever integrate strain imaging in your decision making? And I guess, to suggest a scenario, a patient with excessive trabeculation, normal LV function, EF wise, but abnormal strain, does that change your kind of path? And just how have you seen that integrated into the literature?
I think it's an excellent question. And my sense is that there's probably not enough literature to give a comprehensive answer, but there's at least some suggestion that abnormalities in strain is a signal for potentially developing ventricular dysfunction or worse cardiovascular outcomes down the road, not perhaps as strong as abnormalities on the ECG or late gadolinium, but a consideration. And so I think the next steps, if you were to identify somebody that had a fairly conclusively negative workup, with the exception of just an abnormality in strain, that would probably represent a black box of what the data tells us so far. But in the time of uncertainty, I would assume that erring on the side of caution and maybe repeating an echocardiogram in a couple of years to either repeat GLS to see if that's changing, or if there's the development of true systolic or diastolic function to help clarify the next steps.
Ari, you had a question?
You want to unmute yourself and ask it?
Yeah, I just want to make a few comments just for information. One is that, once you have LDL more than 190, when we do genetic testing, only 5% end up having a monogenic form, or at least we have diagnosis. Probably we don't know all the genes for hyperlipidemia, but at least a large number of them are polygenic. So about 5% going to have positive tests. Your kind of pretest probability is higher if you have xanthoma on your exam. So that's one. The second thing is that you mentioned about your patient having gut absorption and suddenly a drop from 190 to 120. Studies have shown actually these patients who have more contribution of the dietary or gut cholesterol to the total cholesterol are, for some reason that is not completely understood, at higher risk for disease. So, and also be careful that the diet for some person may be low cholesterol, for others may be low carb, and not all the same. So there are very much variety there. And the third thing is actually to emphasize on the role of ApoB levels, because, as you guys know, they initially thought in the genetics that TG is a risk factor. Then we realized it wasn't really TG, but actually VLDL. And then finally, actually European, kind of earlier than us, understood that it's actually ApoB levels. So follow ApoB levels in your patients. is actually much better than just LDL alone.
Thank you so much. That's very helpful, Dr. Mani.
So this was great, both of you. I mean, I learned a lot. So Max, this anonymous cardiology fellow, does he know what his parents' LDL was when they were younger? And if they don't have, I guess they don't have any coronary disease right now or cardiovascular disease, known cardiovascular disease right now. I don't know how old they are right now.
Yeah, so this anonymous cardiology fellow, both of his parents are in their 60s, but his dad is a farmer. He raises horses and lives on a farm in Wisconsin. And true to the stereotype of a farmer, has very little healthcare exposure. And it's almost impossible to get this anonymous cardiology fellow's father in front of a doctor. And so I don't know that there's any data and anywhere in any medical record saying what this person's father's LDL is or whether or not they have subclinical atherosclerosis. But so far, they have not had a hard cardiovascular event to that fellow's knowledge.
But I guess if you had some information that I mean, the HDL was not bad, no?
Yeah.
And if they had a high LDL when they were younger, obviously that would be part of the decision-making process.
Yeah,
I guess.
absolutely. Yeah, I think, genetics are obviously a powerful predictor as well. So if you had more information, you could maybe see if the risk is similar to their parents, who so far have not had any cardiovascular events.
One more question.
Thanks, guys. That was terrific. Both I learned a ton. I just wanted to also just address the diet, and also reflect something that comes from one of our fellows, Eric Brandt, who I still keep in touch with. He's at University of Michigan. And actually in their prevention program, they were able to orchestrate a dietitian meeting with the patients at least 1 month ahead of their visit. And then they try to live their best diet possible. And then they check their lipids. And that's the ones that they use for their risk assessment. But just to reflect that there's like very large heterogeneity in response to diet, and some of the most high lipid levels that I've ever seen are on ketogenic diets, where you have these extreme phenotypes of people who completely carb restrict and their LDLs go above 300, and there's no sign of any FH or, when we genetic test them. And there's a whole culture of people who then do lipoprotein testing and say these are all, not the atherogenic small LDL particles. So anyway, there's a lot of heterogeneity with diet. So I would suggest, trying diet first just to kind of see how low it goes, and then using that as a reference. And it might be that that's unrealistic for that person to maintain. You have to also put it into context of family history and other aspects that it could be both that are contributing, both diet and genetics. But yeah, just another nuance, but lots of messiness in this space and lots we don't know.
Thank you so much.